All right, guys. So I am recording now. All right, I'll come back to that in a second. Okay, so like I said, I want to first just introduce Unit 6 as a whole. And so I just kind of remind you where this Unit 6 overview is. And then there's also just a short YouTube video of an explanation about work of breathing that I think is really clear and concise, and he does a really good job. So I'll pull that up quickly just to show you guys after I do the introduction to the unit, okay? And then we'll get into chapter 17 specifically. So, so anyway, the link, well, it's not really a link. The web, you can copy paste this in. I don't know why. I guess I had to make it a link and I didn't. So anyway, it's in the notes, okay? So if you want to refer to that video that I'm going to show you, it's in the notes on that first slide, okay? I just want to make sure you guys knew that. So let's go back to here and just talk about this unit that we're focusing on this week, okay? It is all focused on disorders of oxygenation, if I could say it. The first chapter, the chapter we're going to focus on today, focuses on restrictive lung disorders, okay? Chapter 18 is obstructive lung disorders, things like COPD, asthma. We'll talk about those in chapter 18. And then remember, chapters 19, 20, and 21 are super condensed, and I'm just hitting high points from those chapters, okay? Again, I think it's important to hit some of these topics, but impossible to cover them all, right? Honestly, this book is definitely meant for probably an entire year, not just a semester of pathophys, okay? Okay, so in restrictive lung disorders, again, I'm not gonna talk too much about them because we're gonna focus on them in the chapter. Let me just pull up I have some little notes here from this intro. These are disorders that will basically prevent expansion of the lungs, okay? So again, we're gonna talk all about that, so I'm not gonna say any more about that. In terms of obstructive lung disorders, a lot of them are caused by inflammatory processes, okay? So like I said, some examples, COPD, asthma, and we'll talk about those as well in a lot of detail, okay? Those last three chapters, there are some infectious respiratory diseases in there, neoplastic, right? So if we're talking about neoplasms, right, overgrowth of cells, and then a chapter focused on respiratory failure. Okay, so again, I will hit the high points on those as well. One thing that they kind of mentioned in the intro that I think is kind of worth mentioning, you know, is this sort of like connection between anxiety and you know, shortness of breath or trouble breathing. Obviously, if anyone is having trouble breathing, it's going to promote anxiety, right? I mean, anxiety itself can kind of trigger changes in breathing patterns as well. And they also mentioned the fact that, like, you know, if you're a mother and your child is having trouble breathing, it's going to probably freak you out a lot. Okay. So, so that's just something to kind of think about. The other thing, like I said, that I wanted to just introduce here is this idea or this concept of work of breathing. Okay. Because this is totally going to come into play in this chapter and others in this unit as well. Okay. So again, this is just an overview, right? Restrictive lung disorders, obstructive lung disorders, again, neoplastic, infectious, and vascular lung disorders, respiratory failure, right? So we're basically hitting on all of these things in this unit. And then work of breathing is what I want to just talk to you or show you that little short video on, okay? So this is the idea in terms of, you know, if you have a restrictive lung disorder or an obstructive lung disorder, it's going to increase the work of breathing, right? Or increase the amount of energy that's needed for you to get enough oxygen and enough air into those lungs, okay? So, and I know we had a case study that kind of talked about this, right? Where there was a patient, I think, that was having some kind of, was having dyspnea, I think at rest, right? And the idea is that if he is expending so much energy to try to get enough oxygen in, right? Or to inhale and fill those lungs, there's not going to be much energy left over for anything else, right? And so the idea of kind of reducing the amount of you know, activity and things like that, because that patient needs to spend so much energy on breathing, okay? So like I said, let me just show you this quick video because I think he explains this really well. And I kind of cut it short just like by a minute or so, but here it is.
The other item that we need to think about with both compliance and surface tension is how this affects the overall work of breathing. So this is how much energy it takes for a person to breathe. To do this, we have to know that the lungs themselves want to collapse. So to actually breathe, you are going to have to overcome the elastic force necessary for there to be collapsing of the lungs. We can use a diagram such as this, in which we have the amount of pressure on the x-axis and volume on the y. We're going to have a number of different denotations on this graph just to help you orient of what part we're talking about. So if you're trying to overcome elastic forces, that is the force between A, B, C, D, and 0. Then back to A. So that's all of that portion that is shaded in that kind of gray-blue. To overcome the non-elastic forces, that is this particular graph where we go from A, E, C, F, A. So it forms that kind of nice elliptical circle there. The inhalation component goes from A, E, C, B, A, or that part that's just on the right-hand side. Or during exhalation, it's A, B, C, F, A. Why this becomes important? If someone has a restrictive lung disorder, it's harder for them to fully inflate their lungs because of resistance in inflation. Therefore, that person is going to need to generate a greater negative pressure to fully fill the lungs. So they are going to take more energy to fill the lungs. Therefore, when they go from A, E, C, F, A, it requires a greater pressure change, and therefore they have to exert a lot more effort to get in that particular air. Obstructive disorders also have a problem with work of breathing. But you notice for this, it really just inflates this particular graph because they have a problem getting a lot of their air out. And so they're overcoming a lot of resistance, so they have to push air out of the lungs. And that can be seen in this diagram where we have A, E, C, D, F, back to 0, and then A.
All right. So anyway, I thought that that was a good explanation in sort of comparing normal work of breathing with, and then what happens in restrictive and both obstructive lung disorders. So actually, if you guys look at the review sheet, I don't even know that I have that on there. So I think that that's something we want to add in, right? So we want to probably add in work of breathing and to be able to, if I showed you one of those graphs, right, recognize, like, for instance, recognize that graph that's showing somebody with a restrictive lung disorder, right, or an obstructive, okay? So, so if you guys, the introduction to the chapter, which I pulled up from the e-text, those graphs are there in that overview figure, right? It shows you almost very similar graphs to what he shows you in the video. But so either or, the video is helpful, but those graphs are also included in that overview, okay? So definitely, you know, we should be able to recognize those graphs, okay? Does anyone have a question about that? All right. Okay, so let's move on and let's just talk specifically now about these restrictive lung disorders and basically concepts that are related to them. Okay, so let me just pull this back up now and we can move on here. Okay, so in terms of learning objectives, they are listed here. Again, you can kind of read through them, but I'll show them, I believe I show them all again right before I talk about them. So like I said, the first one we're going to talk about are factors, right, that will alter ventilation and alter oxygenation, specifically in restrictive lung disorders, and talk about some concepts related to it, okay? So first thing first, I mean, again, and he kind of talked about this in the video, if you have a restrictive lung disorder, right, the issue is that you cannot fill those lungs completely with air, right? there's an issue with those lungs or the chest cavity or something like that being able to expand, okay? So if we say, you know, compliance, right? The term compliance, if you guys look here at the second bullet point, it says decrease compliance or decrease in compliance. What do we mean by compliance? We mean elasticity, right? So meaning the chest wall or the lungs have a decreased amount of elasticity, and therefore it is really hard for them to expand to where they need to be in order to fill them completely with air, okay? And so also, you know, there's going to be a prevention of expansion of pulmonary structures like alveoli, things like that, right? Obviously, if enough air is not getting inside, then those pulmonary structures are not going to be expanded to where they should be, and the air is not going to reach those alveoli, okay? This does lead to altered breathing patterns, right? You're going to see in terms of symptoms of all these diseases, they're all the same essentially, okay? You'll have rapid, shallow breaths. Why? You can't fill your lungs all the way. And so to try to compensate for that, you need to increase the respiratory rate, and they're going to be shallow because you're not able to fill those lungs all the way. Okay. Obviously, this is going to interfere with oxygenation. It will increase the amount of energy requirements, the amount of muscle requirements that are needed to get adequate ventilation. Okay. What also ends up happening is that you get damage to the alveoli, right? And also to the capillaries that are closely, you know, associated with those alveoli. Okay. So then once there's damage there, that leads to more permanent issues, right? And so these all kind of work together to create the symptoms that we'll talk about a little bit later on. Okay. This table here is not something that anyone needs to memorize. It's not, and you can see it's not even on your review sheet, but I think just worth including because these are definitely more uncommon pulmonary disorders. And so I guess it's just the idea of being familiar with them. So like I said, please don't memorize this table. Please don't really spend much time with it. I just put it there to make you aware of some of the more uncommon types of pulmonary disorders that exist, okay? Wait, I've got to decline that call. Okay, moving on, guys. So, and I already talked about some of this, and some of this, like I said, this stuff will keep coming back as we move through. Those altered breathing patterns, right? The shallow, rapid breaths that I talked about are going to compensate for either a non-compliant chest wall. Again, the chest wall is unable to expand, or the lungs are unable to expand fully, okay? So I guess if everyone, you want to kind of, you know, take a big inhale, right? What happens when you inhale, that chest cavity expands, right? And so if the actual chest cavity itself is not able to expand, you're not going to be able, the lungs aren't going to be able to expand, okay? They're going to be confined. I already talked about this abnormal rapid breathing. Make sure we know the scientific term or the medical term for it, tachypnea. And in terms of the impaired oxygenation, right? What's kind of happening and why do we end up with impaired oxygenation? Well, one thing, if you're not getting enough air in the lungs, right? You're not filling them completely, right? You're obviously then not getting enough oxygen in them, okay? And so this first bullet point says oxygen gradient. So what is that referring to? What do I mean when I write oxygen gradient there? What does that mean? We can say that I guess this is disturbing the oxygen gradient or changing the oxygen gradient. So what are we referring to?
Would it be the membrane?
Well, yes, the movement of things across the membrane. And if you think about the membrane, let's think about the alveoli, right? Oxygen and air's in the alveoli. And then that oxygen is going to move across the membrane. And where's it going to move? To where? From the lung.
Oh, to the blood vessels?
Yeah, to the blood vessels, right? You have all those capillaries that are closely associated with those alveoli. And so, right, oxygen is going to move from the alveoli, from the lung, into the blood, right? Through the capillaries, capillary wall. But why would an oxygen gradient interfere with that process, I guess? What do you think? Somebody take a take a guess. What the heck am I referring to by oxygen gradient? And why would that affect the movement of oxygen from the lungs into the blood?
Could it be because enough oxygen is not flowing into the lungs?
Okay, that's true. Yes, there's not enough oxygen there, right? But what do we mean by gradient? Remember, when did we talk about gradient? I guess what kind of, what process just sort of in general were we talking about when we talked about a chemical gradient, right? Or molecules following their concentration gradient. You guys remember? Just a main sort of biological process. When a molecule moves across the membrane, right? How does it move?
Are you talking about diffusion and osmosis?
Yeah, diffusion, not osmosis, because we're talking about oxygen, right? But yes, diffusion, molecules move from what? From what concentration to what concentration?
Oh, from a higher concentration to a lower concentration.
Yeah, good. From higher concentration to lower concentration, right? So normally you're going to have a high concentration of oxygen in the lungs, right? And a low concentration in the blood. And so that drives the movement of the oxygen into the blood. If you don't have a high enough concentration of oxygen in the lungs because of a disorder, right? That gradient is thrown off and that oxygen isn't all going to move into the blood, okay? So that's what I'm referring to there. Does that make sense to everyone? And so the other thing that's listed here too is diffusion distance. And there's a picture in one slide that I'll talk to you guys about. But basically what can happen is that the space, so we're just talking about diffusion, right? The movement of the oxygen from the alveoli across a very thin membrane, right? Through the capillary wall into the blood. If there's something in between and the space between the alveoli and the capillary are increased, there's also no way that oxygen can move into the blood, okay? And so there's some reasons why this happens, this sort of increase in distance. And we'll talk a little bit more about that in a second, okay? Let me just show you the figure that shows you all the concepts related, and then we'll come back to this diffusion distance, okay? One second, guys. Sorry. So if you guys take a look here, right, again, this is the same figure we see in every chapter where it has oxygenation sort of in the middle and showing you all these concepts that are related to it. And a lot of these we're going to touch on as we move through this chapter and through other chapters, okay? So let's look at that figure that I was referring to here. So this is giving you an example of something that's going to increase the distance between the alveoli and the capillaries, okay? So what can happen, and so remember I told you guys that these restrictive lung disorders can cause damage to the alveoli, okay? So if the alveoli become damaged, right, and those are epithelial cells, right? So if they're damaged and some of those cells die, instead of them being replaced with more, squamous epithelial cells, they get replaced with fibrotic tissue. And we've talked about this process before, right? And it just kind of, it happens, right? And so once this fibrotic tissue or fibrosis, like we're referring to it here, gets in there, it basically increases the space between the alveoli and the capillaries. Therefore, that oxygen has to diffuse this great distance, or there's something impeding its movement. It can't move into the blood. Okay, so this obviously severely affects oxygenation, okay? And we'll talk about, or I'll talk about this fibrosis again later on. It'll come up when we talk about another specific disease, but this is one example of how that distance can be increased, okay? So you can think of that fibrotic tissue or that fibrous connective tissue as being like a scar, right? Like scar tissue, okay? Does everyone understand that? All right, so, I think this definitely is one of the figures that I would say is more important in the chapter to kind of understand this, right? So like if I showed you this, I might ask you, well, why is this dangerous, right? This formation of this fibrotic tissue. How does that then affect oxygenation, right? And so what would you say what would be your answer there if I asked, how does the formation of fibrotic tissue, you know, as shown in this figure, affect oxygenation? How would you answer that? Somebody take a stab at it.
Well, you would mention that that fibrotic tissue increases the space between the alveoli and the the capillaries, which prevents the oxygen from diffusing into those capillaries, which can prevent oxygenation throughout the blood.
Perfect. Right? Exactly. That's what I would be looking for, right? That's what we just talked about. This is illustrating a situation where that distance is increased. If that distance is increased, so you have that fibrotic tissue in there, there's no way for that oxygen to move from the lung to the blood vessels. Okay? All right. So let's move on to this, the next learning outcome, which now we're going to talk more about specifics. Okay? Okay. Again, some of this is a little redundant, the kind of first couple of slides, and then we're going to talk about specific situations here. So again, oxygenation, ventilation, these are all sort of are included, because when we're talking about disorders of ventilation, we're saying you can't get enough air in, right? When we're talking about restrictive lung disorders, we're saying the reason why you can't get enough in, right, is because the elasticity of the lung or the chest wall is compromised, right? And so you can't expand the lung as much as it should. It can't fill completely with air. Now, there are kind of various things that can sort of lead to this, okay? And that's what we're gonna kind of talk about. So a neurologic injury in general could impact this, okay? Certain neuromuscular diseases. So any sort of neurological disease that's gonna affect muscle function would, maybe not in every single case, but in a lot of cases will interfere with oxygenation, and mostly with, you know, being able to inhale and exhale properly, right? That ventilation, the act of breathing, okay? So why? What muscles are involved in breathing, right? Again, inhaling and exhaling, that act of breathing. What kinds of muscles are involved in that? Your bicep? Which one? I'm sure you know one. Yeah, diaphragm, good, right? That's one big muscle that sits, you know, between the thoracic and the abdominal cavity, involved in breathing. It has to be able to contract and relax, otherwise you will not be able to inhale and exhale. Also, the intercostal muscles, you know, between your ribs, those are involved as well. That chest wall has to be able to expand, right? And so those muscles are involved as well. So if there's any sort of neurological issue that interferes with the function of muscles in general, it will interfere with the act of breathing, okay? So in the notes here, just so that I remind you guys, I just put some links again, just for like, if we want to refresh our memory in terms of what's MS, right? What's ALS? What happens in muscular dystrophy, right? So that's there for you guys, just for some extra info. Does anyone remember or know what happens in MS? What gets destroyed in multiple sclerosis in your body? Yeah, the myelin sheaths, right? And so that's going to interfere with the transmission of signals, right, from the nervous system to the muscle, okay? What about ALS? Do you know what degenerates in ALS? The actual motor neurons actually degenerate. The neurons actually degenerate. In MS, it's just the myelin sheath. And then, you know, sometimes some of the myelin sheath degrades, but then it can actually be, it can actually come back. In ALS, those motor neurons degenerate and there's no way to get them back. Okay, so again, if you want to look, you know, I provided those links. There's a little extra info there. You know, for this exam, I'm not going to ask you about specifics about those diseases, right? But let's understand the connection between these neuromuscular diseases in general and issues with ventilation, okay? Obesity too. Why do you think obesity might affect pulmonary expansion, I guess? Justina, go ahead.
When you're laying down, like there's like so much pressure on the lungs, so it makes it hard for you to breathe.
Yeah, why though? What's creating that pressure? I mean, you know, right? You're gonna have, right? You have more fat tissue. You have all these. So it's right. It's creating less space there in that thoracic cavity, basically, right? And so less space, again, for the lungs and the chest wall or chest cavity to be able to expand. Okay, so that's another issue that can cause this as well. Okay, so first specific situation to talk about. Okay, so this isn't necessarily a disorder, okay, but this is something that will affect ventilation, obviously, and expansion of the lungs if you have a blockage, right? If there's some blockage somewhere, well, air's not going to get into the lungs, right? And it kind of depends on where that blockage is. So it could be foreign material, but it also can be secretions, right? Or mucus that can block an air passageway as well, okay? Term here, this cafe coronary is basically if there is a foreign material or food, particularly, that completely obstructs an upper airway, that individual can just collapse suddenly, okay? Complete blockage, right? There is no air movement going through, okay? I assume that, don't you guys all have to get certified in CPR? Did you already?
Yes.
When did you guys do that? Last year, freshman year?
I did a couple months ago.
So what do you do if somebody's choking? What does CPR tell you that you're going to do if somebody's choking?
Heimlich maneuver.
Okay, so what's the Heimlich maneuver?
It's
You're supposed to like go behind them and like put your fist like right here, like right where the ribs meet or whatever, like where your sternum is, right? And you're supposed to like pull them against you, I guess. Like
underneath,
push
right?
it out.
And you push in and up, right? Because you're going to try to force that object out. So if somebody is coughing or talking, it means that there is some air getting through, right? And you in general want to encourage that. But obviously, if they're telling you they're choking, right, giving the Heimlich, probably a good idea before it completely blocks, right? Potentially can completely block that airway. And then obviously it's going to be a major issue. So children under 4, right? Older adults, they are at increased risk for aspiration or for choking. Okay. I think this is pretty obvious. In terms of obviously treatment, you got to get out whatever's stuck in there, right? And so sometimes it could be a scope that can go in there and remove it, but other times it could, you know, a completely opening that chest cavity might be necessary. Okay. All right. So this is one situation, right? Aspiration. Okay. We should know what that is. Understand why that you're not going to be able to inflate the lungs or expand the lungs if there is a blockage there. Okay. Next thing to talk about is something called atelectasis, okay? And so what is this? It's a collapsed lung, okay? And there are various degrees of severity and different types, and we'll talk about that, okay? So atelectasis is how you pronounce this. And again, it is the term, the medical term for a collapsed lung, okay? It doesn't have to be a complete collapse. It could just be part of the lung that's collapsed. And again, we'll talk about that in a second. Okay. So it says here, relatively low ventilation in comparison to perfusion. So yeah, the problem is that the lungs collapse. There's no air getting in there, right? You can have primary versus secondary. So primary, there could be a collapsed lung at birth. Okay. Obviously secondary means it's going to develop later on. Okay. Some risk factors in general, immobility. Okay. So if you have a patient that's completely immobile, they are at increased risk for a collapsed lung. Diminished ventilation in general is going to, again, put somebody at increased risk as well. Restriction of lung volume, that's what we're talking about. Fractured ribs, and there are other examples as well. Okay, so these are the 4 different types of collapsed lung or atelectasis, okay? And they basically, we can refer back to this figure, okay? So I'll talk about each one and I'll kind of flip back and forth to the figure that shows you that example. Okay, does anyone have any questions so far? Okay, all right. So first one, resorption atelectasis, okay? So this is caused by airway obstruction. We just talked about airway obstruction, okay? So basically, you're not gonna be able to inhale any more air, right? If there's an obstruction there. So whatever air was sort of behind it in the alveoli, that oxygen can then move into the blood, right? But then there's no way to get any more air in after that because there is some blockage. Now, the blockage could be some foreign material like we talked about, or It could be excess mucus secretion. There could be a tumor that could cause this. Okay, so there are other causes besides just choking on foreign material that could cause that. Okay, and so if you guys look at the picture here, okay, what you're seeing, oh my goodness, what you're seeing here, right, in orange here is that blockage, okay, and basically just past it, you're going to see that there's going to be decreased expansion of the lung in that area, right, because no more air can get in there, right? Make sense? So again, that's a partial, it's not a fully collapsed lung, okay? If you talk about compression atelectasis, okay, if you get any sort of air or fluid or a tumor in the pleural space, this can cause compression atelectasis. So what do we mean by pleural space, right? I added this little picture in here. Basically, you have your lung tissue, right? And you basically have a membrane that encases the lung, and you kind of have one that's really tightly associated with the lung tissue, and then one that's a little bit further away, and there's space in between the two. Okay, so you guys see this? So here's your parietal pleura in red, and then the visceral pleura in blue, and then this is the space. So air can get in there. There can get excess air, excess fluid in there, and what happens is if enough is in there, it's going to basically sort of create more space, and then it can compress on the lung and cause it to collapse. Okay, and we will talk about diseases or disorders where you have accumulation of air or fluid in that pleural space. Okay, there it is every Monday. Okay, questions about that, guys? So like I said, we're going to talk more about that, but all right, so let's go back. So contraction atelectasis. So we talked about fibrotic tissue, right? So it says here, fibrotic changes. Basically, if you're getting more and more of that scar tissue that's forming, it basically can, again, create pressure and kind of push on that lung and cause collapse. So the idea is that you have this fibrotic tissue, more and more of it that's sort of forming out here, and then basically confining the space of that lung and causing collapse, okay? The last one, microatelectasis, is referring just to collapse of the alveoli. So obviously this is much smaller scale, and it's something that you're not going to be able to detect with a chest x-ray or anything like that because it's microscopic, hence the name, okay? So that's here. All right, so we should be familiar with these different types of atelectasis, okay, and what's essentially causing them. Are there any questions, guys?
Okay. What type of tests would you do for that microallostasis? Would you go off symptoms and then do further lab testing?
Yeah, pretty much. You would have to go off symptoms. I mean, and then if there are still symptoms, then maybe there would have to be something that would be causing it, right? And so if it was something that was causing symptoms that you couldn't detect with a chest X-ray, then you would know that it's got to be a little more, fine-tuned. So I don't know that there's something specific that you could directly assess exactly what's going on with the alveoli. But yeah, you would have to go with symptoms, and then maybe it might warrant doing a biopsy or something like that, right? Does that make sense? There's no imaging technique that would be able to show you those alveoli themselves. In terms of clinical manifestations, again, you're going to see these same clinical manifestations, each thing that we talk about as we move through this chapter, okay? Difficulty breathing, right? Rapid breathing. We should know the medical terms for these as well, right? Dyspnea, difficulty breathing, or shortness of breath, right? Tachypnea, tachycardia. Cyanosis sometimes will develop too, where you can see this blue coloring of the skin, which indicates there is not enough oxygen, right, being transported around or getting to those extremities is usually where you see it first. If you're going to assess breath sounds, right, you basically you could maybe not even hear any breath sounds over where the collapse is, or they would be diminished. Okay, so that's another sort of clinical assessment that's used. In terms of treatment, right, you gotta focus on what the cause is and try to treat that. this here, and maybe you guys have heard this term before, this pulmonary toilet, which apparently has been replaced by pulmonary hygiene, but there are exercises and procedures that can be done to help clear the airways of mucus and other secretions. And so that probably would be something that might be necessary if this is due to an excess of mucus accumulating in those airways, okay? All right, questions, guys, before I move on? All right, so if we go back to where we are, you know, on your, just a reminder here, on your review sheet, right? You know, I referred to the figures that we went over. Make sure you're defining atelectasis. On the review sheet, you should have the 4 different types and a short definition for each one that we just went through, okay? The next thing we're gonna talk about is pneumothorax, okay? So that's the next thing we're gonna talk about. And then, like I said, we'll talk about a few more sort of disorders as we move on. Questions? All right. So I told you that I was going to kind of mention this or talk about this a little bit more when we're talking about that pleural space, right? So pneumothorax is the presence of air or excess air between or in that pleural space, right? Between these 2 different pleura. Remember I showed you that picture, okay? And so what happens is if there's an excess of air in there, it will compress that lung tissue. And we kind of saw that in one of those pictures already, okay? Now, a lot of times this will happen due to trauma, right? A chest trauma, but it can also happen as a result of disease, okay? And it can also be spontaneous as well, okay? In terms of trauma, you can have a blunt trauma to the chest, but you can also have a penetrating chest wall injury that can lead to this as well, okay? The pneumothorax can also be caused by medical procedures. So particularly medical procedures like thoracentesis, right? Where you're trying to remove fluid that's accumulating in that pleural space, right? So fluid can accumulate there, and we're gonna talk about that next. If you had to undergo that procedure to try to remove fluid, right? It could then create another issue where you have more air in there, which also presents problems, okay? So this can be caused by or as a result of some medical procedures, okay? Also a reminder, because we're not gonna talk about pulmonary edema specifically in this chapter, I do believe we talk about it a little bit more, almost like 99% sure. I talk about it a little bit more later on and I forget which chapter. But I just wanted to kind of put a little side note here to remind us, you know, what pulmonary edema is. And obviously this is something that also affects or compromises lung function as well, right? Remember we talked about this? If you have an accumulation of blood kind of in the blood vessels that are around the lung because the heart's not working properly, right? It causes fluid to basically seep out of those blood vessels, right? And you're getting that excess fluid basically between the capillaries and the alveoli. And then if there's excess fluid there, again, oxygen's not going to be able to move from the alveoli to the capillaries, just kind of like we talked about before, okay? So reminder about that. Like I said, more to come about that in a later chapter. Okay, so I mentioned that this pneumothorax can actually occur spontaneously, okay? And so there is a disorder called primary spontaneous pneumothorax, right, or PSP, okay? And so it kind of starts with this bleb, this small sort of air sac on the surface of the lung, and that then kind of gets worse as this disease progresses, okay? Or the bleb gets bigger. And so apparently there is a 6 to 1, an increase in incidence 6 to 1 in males versus female, okay? If you add smoking into the mix, okay, it will increase, in men, it will increase the chances of getting PSP by 22 times, and in women 9 times. So obviously smoking basically exacerbates this issue, but this, like I said, this can just be spontaneous. This bleb forms and then it starts kind of getting worse and creates issues because now you're getting more air that ends up in that space, okay? some other terms here, and I kind of already alluded to this. So if you talk about a penetrating chest wound, right, like a stabbing or something like that, that's called an open pneumothorax, okay? If you had a blunt force trauma, the chest wall is intact, it's called a closed pneumothorax. And again, what do we mean by pneumothorax? You have air accumulating in that interpleural space. There shouldn't be air there, okay? But there's an injury, there's a disease process or something that's causing that air to accumulate there, okay? Now we're gonna talk a little bit more about two different types of pneumothorax. So tension and non-tension, okay? So tension is gonna be more dangerous and is a medical emergency off the bat, okay? Again, usually caused by injury, okay? So air will enter into that pleural space, but it's never able to leave, right? So if you think about it, when you're during inspiration or inhalation, right, the air will enter into the lung, and if there's some injury, it can enter into that pleural space. But then during exhalation, it might leave. Well, in tension pneumothorax, it doesn't, okay? So it stays there and it never leaves, okay? And so in that case, the lung and the heart are gonna be compressed severely, and it is a medical emergency. In non-tension pneumothorax, and I'm gonna show you a picture in a second, air actually can exit during exhalation, okay? So if you guys look at this picture here, that's what this is showing you. Here's tension pneumothorax and non-tension. So again, yeah, if I showed you this picture, I could ask you which one is an example of tension pneumothorax and which one is non-tension. We should be able to recognize that, okay? So what's going on up here in tension pneumothorax? Again, in the inhalation, okay, you're getting this interpleural space pretty greatly filled with air here, right? This lung is completely collapsed and compressed, and so is the heart, okay? During expiration, that air never leaves. And so the lung and the heart continue to be compressed, okay? And they're not gonna be able to function. So unless you get rid of this air quickly, that's it, the patient's gonna die, okay? In non-tension, during exhalation or expiration, that air leaves. So you don't end up with this sort of ongoing compression. There's like a semi-relief during exhalation. Still dangerous, but not, I guess in terms of time, you have a little more time here than you do here, okay? So does that make sense to everyone? Okay, so same thing, there's an injury, there's damage. There's a hole where there shouldn't be, right? And air is getting into the interpleural space when air should only be in your airways, right? And inside the lung. It shouldn't be outside in any sense, right? In this tension pneumothorax, it's actually never even able to leave. And so more and more air keeps going in there and keeps pushing on the lung and the heart. And again, it's a medical emergency, okay? In non-tension, some of that air leaves during exhalation. All right, in terms of clinical manifestations. So if this is only, affecting about 15% of the lung, there may not be any symptoms at all. If you're talking about over 40% of the lung involved, here you go, the same symptoms that we talked about before, okay? What about ipsilateral? What does that term mean, guys?
Isn't that one side, it affects one side, but not the other?
Yeah, and so if you're thinking about like an injury, if the injury was kind of on one side, the ipsilateral side would be that one side versus contralateral, which would be the other side. But yeah, the idea is that you're only gonna have pain where that's happening, right? So like it would be on, this side here. And so it indicates that there's something, some sort of injury or some sort of something going on one side, right? So it wouldn't be a process that was kind of affecting overall lung function, sort of something specific like this, yeah. Says also too, obviously it's gonna promote anxiety, would imagine, right? You got probably severe chest pain and you can't breathe. And I mean, in general, I talked about that at the beginning. Anxiety definitely is tied to shortness of breath and trouble breathing and that rapid breathing. This is all going to evoke an anxiety sort of process, right? In terms of like clinical assessment, it says no, so you may not even hear breath sounds, right? If you're basically, you know, tapping and trying to listen to see where you're going to hear that resonance, there will be this sort of drum-like quality that you hear where that pneumothorax is located. Okay. So again, that's more pertaining to actually listening to those lung sounds. So there are certain things that you can sort of listen for and assess that way to kind of get an indication as to what's going on. Okay. All right. So in terms of diagnosis, right? Physical examination, we just talked about that. Obviously, what the presenting symptoms are, we talked about those. Chest X-ray, CT scan, all of these, you know, these types of imaging techniques are really important in most of what we just talked about, right? Because you can actually see what's going on in the lung. You can see the collapse. You can see that essentially this extra space there that's not supposed to be there. Okay, so imaging is super important here. What's treatment? You got to insert a chest tube into that interpleural space and get the air out, right? To relieve that compression on the heart and the lung. Super important. All right, are we all right with that? So again, for pneumothorax, basic definition, it's what? What's happening in pneumothorax? What are you going to write on your review sheet if I told you to write, you know, a 3 or 4 word definition for pneumothorax? What is it?
Air in the interpleural space.
Air in the interpleural space, okay? Excess air accumulating in the interpleural space. Again, in general, you know, or commonly it's caused by trauma, right? But can also be caused by other reasons as well. But the biggest one I would think to kind of think about this is trauma, okay? All right, now, with that being said, so that was air. Now you can have fluid that accumulates in that interpleural space, and that is called pleural effusion, okay? So this is not excess air, this is excess fluid, okay? Again, in that pleural space, okay? And there's kind of, you know, a couple different reasons or sort of factors that can contribute to this, okay? So it says here, increased production, right? Or decreased draining of fluid, okay? So again, normally there's some fluid there, but you're gonna have excess fluid accumulation, okay? Thoracic abdominal surgeries can lead to some excess fluid there. Inflammatory processes can also contribute to a fluid buildup in that pleural space. Atelectasis, what was that again? Oops. What does atelectasis mean?
A collapsed lung.
A collapsed lung. That also can lead to accumulation of fluid in that pleural space, okay? Blockage of lymphatic drainage. So what are the lymphatic, you know, the lymphatic system, right, carries around and kind of picks up excess fluid. It's also involved in sort of immune function, right, and delivering some of these immune cells. And so if there's a blockage in a duct or something like that, it's not going to be able to pick up that excess fluid and you'll get accumulation there, okay? Also, it says here, decreased plasma proteins. Remember we talked about this? I don't even know what chapter, but we talked about and when we're talking about kind of fluid, you know, moving out of the blood vessels, right? And that if the levels of plasma proteins are off, right? Sometimes because of like malnutrition or something like that, we talked about that can cause fluid to basically leak out of the blood vessels and end up in that interstitial space. Okay, so here it can end up in that pleural space. Okay, I mean, I kind of already said this, right? So it says here, you know, causes. If there's a blockage in the lymphatic system, you can end up with excess fluid. So sorry, that's a little redundant. If you talk about heart failure, particularly left ventricular failure, you can end up with this excess accumulation of fluid, kind of for the same reasons that we talked about with that pulmonary edema, right? That I kind of mentioned. I mean, this is kind of the same thing, right? You're getting fluid sort of leaking out of the blood vessels. When you think about pulmonary edema, you're specifically thinking about excess fluid in the interstitial space between the alveoli and the capillaries there. Here, the fluid is accumulating in that pleural space. Okay, so it's just kind of a difference in location, I guess. Also, cirrhosis can cause this. And again, I think I already said that, but a collapsed lung can cause this as well. Okay, So just like a lot of these, right? If it's small or if there's not a lot of fluid accumulation, it's probably not going to lead to any symptoms, okay? However, if there's a lot of fluid accumulating there, it's going to lead to the same symptoms we talked about already, okay? One thing to point out, and again, you guys don't need to, know these different types of fluid, but I want you guys just to be aware that the type of fluid that accumulates there, it is going to be important, I guess, in sort of diagnosing what's going on, right? So if there are a lot of white blood cells in that fluid, it indicates that there is some sort of immune issue or potentially, right, an infection or something like that, okay? Versus other types of fluids. So let me just pull up that table just to show you. Again, this is something that you don't need to know for the final exam, but I want you guys to be aware that there are sort of differences in what type of fluid accumulates there, and then that will give you clues about what's going on, okay? So let me just go to the e-text again, and just to show you that real quick. That's not where I meant to go. Hopefully it didn't log me out. Oh, I don't think it did. So does anyone have any questions so far as I'm, just trying to find this? Like I said, I just want to pull it up so that you guys have it and just are aware of it, but not something that I'm going to test you on the final exam. Questions so far? Do you guys have your review sheet for chapter 17 pretty much almost completed? Come on. It's coming. Maybe. Wait. Sorry. It's here. Right, so this is the table that I'm referring to there. Again, do you guys need to memorize any of this? No, but understand that depending on what type of fluid is there, and what are the components of that fluid, it's going to give you some more information about what's going on, right? So if there are neutrophils and other leukocytes, right, in that fluid, it's going to indicate probably infection, right? Potentially cancer, okay? So again, it gives you information about what's going on. All right, so let me go back to the lecture. Okay, so any questions so far? No? Okay. All right, again, for diagnosis, important, these imaging techniques, chest x-ray, CT scan, again, important. In terms of treatment, you got to get that fluid out of there, right? There's actually a type of procedure that, so if this is something that's an ongoing issue, right, accumulation of fluid in that pleural space, you can actually adhere your lung to the chest wall and it will seal up that space. So obviously if that space is sealed up, there's not going to be any fluid accumulation. And obviously this is going to be something that's done if there's an ongoing sort of major issue with this, okay? It's not like, I guess, procedure that would sort of be used as a first line of treatment, okay? All right, now the next part of this, where are we here? Yeah, so the next part of this lecture talks about chest wall abnormalities themselves, okay? So remember we said, if the chest wall is compromised, okay, it's going to affect how much that lung can expand, okay? So again, traumatic injuries can affect that chest wall and then therefore affect how much it can expand. We talked about muscular disorders that can affect that as well, right? But there are also congenital conditions that affect the chest wall and therefore then might interfere with ventilation, okay? And so we can talk about these different types here. So again, terminology, right? This is caused by injury again, right? So a lot of what we've been talking about, a lot of these issues are caused by injury, okay? So for flail chest, it says it results from blunt chest trauma with multiple rib fractures, okay? So the idea is that you're gonna have lots of rib fractures and things are unstable, okay? So again, that rib cage completely encases the thoracic cavity, right? And it's super important. In fact, you know, if you have a bone disorder where the rib cage doesn't form properly, some of these diseases, infants will die, you know, within a month or two because of the bone not being formed properly. Okay, so super important that thoracic cavity is intact, okay, just for the sort of act of breathing and ventilation. Okay, again, clinical manifestations, dyspnea, painful inhalation. Why? Because you got ribs that are probably potentially moving around and can be kind of sticking into things. Unequal chest expansion, because again, you're gonna have broken ribs and some compromise at somewhere wherever the injury occurred. Can lead to hypoventilation, hypoxemia. Here, this is this crackling sensation that you can hear that that's caused by air kind of getting where it shouldn't be, okay? Super important that, again, you stabilize that chest wall, okay? So here, again, if we're talking about flail chest, it's the idea that it's unstable and there's like movement. And think about it, if you have broken ribs, things moving when they shouldn't be, you lose that stability that you need for normal ventilation, okay? So flail chest is caused by injury. And again, it's when you will have multiple rib fractures. You know, a couple fractured ribs probably doesn't lead to flail chest. This is a pretty serious injury and a serious sort of amount of fracture that you have there, okay? Now, you can also have chest wall deformities that just happen by chance, right? Sort of congenital deformities. And here are two examples, okay? So pectus excavatum, okay? This is where you have sunken or concave, okay? You sometimes hear it called funnel chest. And I'll show you guys a picture in a second. It says here it causes a mild restrictive defect with exercise. So I guess depending on how concave and how severe that deformity is, it could potentially affect breathing. So like I said, if it's major, it might require surgery. If it's minor, maybe it just kind of looks a little off, but it might not even interfere with ventilation at all, okay? In this case, the common term is called pigeon chest. Now it's convex, right? So it's kind of this pointedness that can occur. And again, it says it interferes with compliance of the chest wall because it's more narrow, right? So you're gonna lose that expansion that's necessary. It's going to confine the space of that chest wall, okay? And in this case, it says most of the times people are asymptomatic, okay? So it's not enough to confine, but if it's severe enough, it could potentially lead to issues. And so again, if it is severe, surgical correction might be necessary, okay? So, I mean, I guess if you thought about, you think about this, like maybe you have a patient, who sustained some sort of chest injury, but then also might have this slight deformity. You could imagine that injury could be, have much worse effects on that patient versus maybe a normal patient, right? Though this deformity might not create issues sort of normally at rest, there could be more issues if there's an injury or some other, lung disorder that happens later on, okay? So that's the way I would kind of think about these types of deformities. All right, questions about that, guys? Okay, so here's another, again, sort of deformity, right? That can occur. So we've probably all heard of scoliosis before. Okay, so this is kyphoscoliosis. So you have lateral and back to front curvature of the spine, right? So there's abnormal curvature of the spine that's going on here. Okay, for kypho, it's the sort of hunchback kind of deformity, right? That's and then, like I said, it also has a lateral type of deformity too. Okay, so if you think about your spine, it's sort of protruding out here in the thoracic part of it, right? And if you think about that, if you kind of hunch your shoulders over, what are you doing? You're confining the lung space, right? You're confining that chest space. So this severely limits chest mobility and can impair ventilation. Okay, so again, it can be congenital, neuromuscular disease can cause this as well. Okay, osteoporosis, we probably have seen, kind of think about that too, right? You see that in osteoporosis. Why? Because osteoporosis is starting to kind of cause, you know, weakening of the bones, right? The spine of the thoracic cavity, and can lead to that as well. Okay, if I guess some of the treatment there are braces that can kind of help sort of correct the deformity, right? However, I guess if it's congenital scoliosis, those braces really don't help. So potentially, I guess surgery could correct something like that as well. Okay, the last part of this lecture is to specifically talk about pulmonary compliance. Yeah, we only have a couple more slides, so we might as well finish this. Does anyone have questions so far? All right, so we might, like I said, we might as well finish it, right? Remember, when we talked about compliance, what does that mean? It's basically this, or if you say you have decreased compliance, there is a decrease in the ability of those lungs to stretch or expand, okay? So particularly these disorders that we're gonna talk about, there are problems with the elasticity of the lungs, okay? So apparently there are about 200 different types of conditions that involve reduced compliance of the lungs, okay? And so again, if you're talking about interstitium or interalveoli, this is kind of in between those alveoli, those spaces there, okay, where you're gonna have particularly this decreased compliance. And so remember, if you're not able to get air all the way into the lungs, right, and have those alveoli fill properly as much as they should with air, that's where there's going to be an issue, right? Not enough oxygen there to then be transferred to the lungs. I mean, to the blood, sorry. Okay, now there are various causes to this. So there are some pharmacologic agents, right, like antibiotics, and also chemotherapeutic agents that can lead to decreased compliance, okay? Pollutants, toxins like asbestos, tobacco smoke, they also can affect this as well, okay? There are other types of animal feces or bird droppings that can affect this as well, okay? So you can see there's definitely a whole bunch of sort of environmental exposures that can affect that sort of ability of the lungs to stretch or expand, okay? Maybe we never really kind of thought about that. There are also medical conditions. Rheumatoid arthritis, also lupus can affect this as well, okay? Okay. Now, so again, these are all sort of things that can affect compliance. They're obviously not specific pulmonary compliance diseases, I guess, but this next one is. And so this pulmonary fibrosis, I told you I was going to talk a little bit more about this. It says it's idiopathic pulmonary fibrosis. So what does idiopathic mean? What's idiopathic mean?
The cause is unknown. Cause
is unknown, right? So again, like we mentioned these causes here, these are known causes to affect compliance of the lung, okay? And I mean, after prolonged exposure, you could have some permanent damage that occurs, right? You know, acute exposure of these, it may not lead to any sort of permanent damage, but these are known to affect lung compliance, okay? This disease here, we don't know what causes it. But apparently it is the most common lung disease of unknown origin, okay? It is progressive and it is lethal, okay? So it's actually pretty nasty. So what happens, and I sort of alluded to this in the beginning, right? When we saw that figure that you saw the fibrotic tissue form, it says it results, so again, we don't really know what causes this aberrant repair, right? But what happens is there's damage to those alveolar epithelial cells, okay? And for whatever reason, they're not repaired properly. So instead of more epithelial tissue being produced to replace the damaged ones, you have fibrotic tissue that replaces it. And this can occur with inflammation as well, too, or not, okay? Either way, it's still gonna be a problem. Okay, so again, it says normally epithelial cells will restore the intact epithelium, okay? And it says here, the myofibroblasts, if I could spell it right, will undergo apoptosis. So it's the idea that you don't want those fibroblasts, okay? That's the source of that fibrotic tissue or that scar tissue, okay? The idea is that you would want the epithelial cells to sort of reproduce and proliferate and replace those lost epithelial cells, and those myofibroblasts to go away and to undergo apoptosis, okay? But what happens in this disease is that you get more of those myofibroblasts produced, and for whatever reason, those epithelial cells are undergoing cell death, okay? And so basically, the entire sort of basement membrane of that epithelial tissue, remember the alveoli is squamous epithelial tissue, okay? It just becomes completely destroyed and replaced by this fibrotic tissue, okay? Does that make sense to everyone? So this is an aberrant repair process. And for whatever reason, there's damage that's occurring anyway, initially. Instead of the body repairing it properly, it's replacing that epithelial tissue with scar tissue, right? Or these, and with fibroblast cells, okay? It says here it may be genetic. So there's studies that have shown that there is a genetic sort of component to this. But again, we don't really know what causes it. So in early stages, right, there will be areas of normal lung, okay, where you don't see any of these fibroblasts, okay? And then you'll see some area with some inflammation going on, okay? And maybe some areas where you see some of this fibrosis happening, okay? But as that disease progresses, think about that figure that I showed you in the beginning, you start to see these honeycombed fibrotic areas, pretty substantial, okay? And once that occurs, it's completely irreversible. You can't get rid of that fibrotic tissue, okay? That's it. Once that's there, there's no way you can get back the epithelial cells or get back the integrity of the alveoli, okay? So if the alveoli are destroyed, there's just no way to get oxygen from the lungs into the blood. I mean, and ultimately, if that can't happen, how are you gonna, there's no way to transport oxygen around the body, right? And so you're pretty much, there's really not much you can do, put it that way, okay? So again, we talked about this, right? You get this increase in diffusion distance, right? Obviously, increased work of breathing to try to compensate for this, okay? This, I don't know. So, you know, this figure, just so you know, it's not a figure I probably would use on the exam. So if you want to make a note of that. But the idea, again, is that there is some sort of stimuli that's inducing injury, right? And instead of the lung repairing that injury properly, it's not, right? And so again, you have this aberrant wound healing that occurs, and then this fibrosis, this formation of this fibrotic tissue, okay? It can occur with inflammation, okay? And this is just giving you an idea. This is specifically referring to different types of immune cells, okay? So don't even worry about that. And that this actually can be related to some genetic factors, that sort of inflammatory part, all right? But again, what I want you to understand from this is that there is something that's inducing damage to the alveoli, to the epithelial tissue, right? The alveolar tissue, and the body is not able to repair that properly, and instead is replacing that tissue with fibrotic tissue, okay? So again, if you go back to be honest, it probably is like, should that picture have been here? You can go back to this and refer back, right? This is what this is showing you, IPF, right? Idiopathic pulmonary fibrosis, that's what we were just talking about. And so this is what's happening, okay? So we already talked about it a little bit, but now more specifically within that disease, we talked about what causes that is that aberrant repair process, okay? Questions about that, guys?
I'm just a little confused for what honeycombed means. So it's just, yeah, I'm just confused for what honeycombed means.
I think, so all it really means is, I guess you get this clustering of the fibrotic tissue, and then there's spaces where there's kind of air trapped in between. I think that's all it means, right? So instead of it being kind of this solid tissue, you have kind of parts where you have this clustering of that tissue, and then, like I said, space in between. That makes sense? All right. So in terms of clinical manifestations, so it says here, insidious onset. So it kind of seems harmless because in the beginning, you may not really have many symptoms, but what's actually happening is super serious and irreversible, okay? So then it starts to sort of progress from there, all right? So it says here, deterioration secondary to infection, right? So again, kind of this process is already starting. You may not have many symptoms, but then maybe you get some sort of infection, and that kind of makes that process sort of increases this sort of aberrant repair, okay? But eventually it will necessitate a lung transplant because again, that is irreversible damage that occurs. Okay, I believe this is the last 2 slides here. Yeah, okay, so sarcoidosis is another disorder, okay? And here, you're not getting fibrosis, right? You're actually getting the formation of just areas of inflammation called granulomas, okay? And again, this is of unknown origin. You end up with these granulomas not only in the lung, but in other places as well, in the lymph nodes, the skin, the eyes. And it is most common in young African-American women. And again, in terms of causes, we don't really know. Seems to be a genetic predisposition. There could be some sort of exposure to something that's sort of triggering that disease process, but we don't really know what. If you kind of look again at a chest x-ray, you'll see these sort of areas here where you have this increase in inflammation. So for whatever reason, there are these foci or sort of focused areas of inflammation that occur. And again, not only in the lung, in other parts of the body as well. And so same thing, a lot of times it sort of starts off as asymptomatic, but then can get worse. Okay, so if you start to have some of these, difficulty breathing, again, do a chest x-ray, you may be able to pick this out or identify this, okay? Treatment is corticosteroids. So how come they give corticosteroids for this?
Does it reduce inflammation?
Yeah, reduces inflammation. So like I said, really what's going on here is just this increased inflammation in certain areas of the lung and other areas of the body. And so treatment is to give a steroid to decrease that inflammation. All right, so that's it for chapter 17, guys. So like I said, I'll post this recording up so you have that, entire chapter 17 recording there to refer back to if you need to. And then either Wednesday, we'll do the same thing. We'll do chapter 18 in class like this, or I'll pre-record. It really just depends on what I have time to do. And then again, like I said, make sure all of unit 6, you guys have that done by this week, right? Moving into next week. That unit 6 quiz, I will probably make available later on Wednesday, and you'll have until the end of the night on Sunday night to finish that, okay? So then again, moving into Monday, we have unit 6 done. So remember that there's 2 case studies to do as well, okay? And then there's gonna be a quiz. So make sure you sort of kind of try to find time to really sort of buckle down and focus on the material and study that material, okay? Use the review sheet, take notes on the review sheet. That is super helpful. If anyone has any questions, I will, sorry, choke, stay on.